Remember that slide I showed you where you have part of it is that if the blood is too thick, it causes trouble, so you give them a little fluid, but you only do 1 to 1.5 times. Some people just flood people. If your lungs are otherwise healthy and you don't have sickle cell, that would work, but here you can't do too much. And one of the things we're always doing is cutting down how much fluid the ERs are giving the patients. The second one is you really have to watch the pain management when people come in. If someone is so sedated they can't breathe well, you're setting them up for acute chest. Well, so they got bad pain, so how do you handle this? One of the things that we've done, and actually Dr. Ruckmiller did this years ago, it was published in the journal, that if you do an incentive spirometry every 2 hours, those crazy little machines they give you, 10 times every 2 hours far away, it dramatically reduces development of that. And part of it is you have to be awake, and the nurses have to wake them up. And one of the things I often do is I have people, even though they're not wheezing, I'll give them inhalers, nebulizers, and with pre and post, because even if they're not wheezing, I'll see sometimes 200 to 300 milliliter increase in outflow, because they're having something going on. And again, it's just the interaction. And also the albuterol actually has a little stimulant effect, so it keeps them a little more awake. So that's actually two things that do help. The other key things are antibiotics, and you have to have both. These are just technical names for the two classes that cover all that list of stuff that we saw. Most people will get ceftriaxone and levothyroxine, which is fine, but you need both of them in there to cover everything, even if the cultures are negative. Because half the time when we do the studies, you don't see it in the blood culture, but you can get it out of the lungs if you actually look. So again, you're trying to stop anything from building up. And the most important thing we do believe, and I'll tell you why we say we do believe, is getting transfused early and often. One of the reasons that we think that we have had such good effects or trouble with sickle cells, any hint of lung trouble, we just transfuse. They were actually trying to do a randomized, multi-center study, but that was right when the NIH decided to completely revamp all the sickle cell centers, so the study fell apart right in the middle. But it is, if you will, a strong expert opinion, if you actually look at the NIH guidelines, to transfuse with any sign of lung trouble. Because when that starts to happen, it does seem to break it up. It's almost like getting any blood that won't sickle helps stabilize the vasculature. And so that's one of the things when you want to be, if you're advocating for someone, you will really want to let them know. We often can use single transfusions, sometimes even a unit. Yes?
What happens if you get anything that's approximate to that?
The first question I'm going to ask is, why can't you be transfused?
Antibody, I mean, there's a whole...
Right. The circle, that's why I wanted to make sure.
Yeah,
So for the antibody one, there are a few people that really can't. I'll grant you that. We can do genotype matching if we have to, but if you really can't get transfused, then you just have to be doubly aggressive on everything else, just to make sure that goes in with the fluid. Acute. Sure.
So, how do you get somebody that needs to be matched? Is it you pay for that? Does the doctor offer for it? I mean, I know a lot of our community has this.
For transfusion?
Yeah.
Well, again, only with the doctor taking care of it would know to do this. And that's why, the doctor would order it. And that's why sometimes they're not doing it, you need to talk to them, and actually one of my slides says, call the consult early if someone's having any lung trouble, because otherwise you'll get too far behind them. Once the cat's out of the bag, it's hard to pull it back in. All right, so quickly on transfusions, because I know I'm doing okay. I'm not more than halfway through. Even sometimes one unit seems to help. And they've actually done studies, not directly on this, but with surgery, giving someone 1 unit of blood dramatically decreases their complications from lung troubles after surgery, almost to the background population. They tried it in England, they did the study, that they tried not to give transfusions, and they just had trouble all over the place, mainly acute chest. So even 1 unit seems to, you can get 1 unit, and it just seems to do a long way to help stabilize stuff. This just means, in some places, we can measure how much sickle hemoglobin is left really quickly. Most places, it's send out and we'll get back for a week, so it's not that helpful. But if you can measure it, it's good, because we can really try to drive it down. But if you really can't, and they're sick, we just give them a lot of blood, because we know that's going to do it. You can kind of guesstimate. If their counts are already high, say 9 or 10, and you're giving them blood, you give them more than 1 unit, you can actually decrease oxygen delivery, because it thickens up the blood from the sickle cell. And that's where you have to use that exchange transfusion. Some people call it pheresis. Have you heard of that? If someone's really sick, moderate to severe sick with their lungs, or their counts are high, pheresis is what you need to do. And that's why, again, we're really aggressive with that. And we've convinced most of the doctors in our area too, that that's what they need to do, so they're just like, they're usually calling me now instead of me calling them. Okay, and now if someone's really worsening, you need to basically make sure they get transfused, make sure they're going to use pheresis or not. If they're really getting sick, they need pheresis. But the other thing is also, just like Dr. Jackson said, all pain is not sickle cell, all lungs are not acute chest, even though it can look like it. You need to look for other things. For example, here is a 13-year-old who, again, it's going to be called acute chest, because once you get the process going, it all runs together. But what they actually had, she actually wound up having a lot of mucus plugging. This is actually pulled out of the lungs. Yeah. And that's actually, so you got to make sure you're not overlooking anything else. I have patients who have severe asthma that sets off everything, but you have to treat the asthma with, two, or you're just not going to get anywhere. So that's kind of what a good lung doctor should be helping you with. Some people still try inhaled nitric oxide. It's probably not bad, and there probably is a subset of people, especially if you're really hypoxic, that works for. There's a couple of tricks with this. We did a study looking for inhaled nitric oxide for pain, and it didn't work. But some people don't do it for acute, for adults. They do this all the time for kids with certain babies with certain conditions. So it's almost every intensive care unit has this already. They use it for pulmonary hypertension of the newborn and some other things. So if someone's really sick, it's not bad to do. There's really no side effects, and it may help. Another trick that you can do is that you can give IV arginine, which is another, you put it in TB index, and like a gram or so a day, up to 10 grams 3 times a day. Well, actually it gets turned into nitric oxide in the body. So for a few days, it's another thing that we often do when people are really sick. So there's some other things that can be done, but the important thing is you're trying to protect the blood vessels as much as you can. All right, so what don't we know? Well, I'm always fascinated by the fact that we see so little acute chest anymore, even though it used to be such a common thing. I think partly so many people on hydroxyurea. But when we do see it, they're usually people that are otherwise extremely healthy, and they just go down. And it's just really, really quick. So it's something we're always paying attention to. Because the darn thing with sickle cell, you don't get a break. It's pain, it's pain, it's pain, it's pain, and then you get sick as stink really fast. If someone's not paying attention, that's when things happen. And so every time they come in, you always have to reevaluate, and make sure you're always asking yourself, could this be a precursor to anything bad, strokes, acute chest, or any other trouble? The incidence, which means how often it's happening, does seem to be changing, probably again because of hydroxyurea. There's a question that's been out there for a while: do steroids help because of this inflammation? Why wouldn't they help? They did a study where they put people on steroids, they did better, but when they came out of the hospital, they did worse. So they were thinking there should be some sort of tapering regimen they could figure out, but they've never quite got that out. We will use it. If someone looks like they're really sick and getting bad, we just count them, and then we'll figure out how to taper it later. But anything up front, we don't want to wait until we're trying to limit damage as fast as possible. And we talked about the IV arginine, which actually gets turned into nitrous oxide. It should be nitric oxide, and then these other things. And then one of the other things that's actually worked out at our place, there is this marker that they still keep playing with that in small studies almost perfectly predicts when people are going to develop acute chest. It's like one of the earliest changes, but it's not commercially available, and they're still trying to tune it up. It's been floating around for a couple of years. But just something to keep an eye out for. Are there better markers that you can look for? All right, so last few slides, take-home points. This is the first I'm confused from. One, if someone comes in, if you go in and you have sickle cell, or someone you know has sickle cell, they go in, if they have any sort of respiratory trouble, especially with fever, they need to be evaluated. Usually an x-ray may or may not help early on because it can take 2.5 days for it to show up, but they need to be watched. We will not necessarily admit everybody, but we watch them every day just to see if they're getting any worse, if otherwise they look stable. Second thing you do, if they do come in, try and get that pain under control. Get them on incentive spirometers, get them on some sort of inhalers to keep them awake, and just keep an idea. You just don't want them sedated in the bed. You're setting them up for what could be a far pain's bad enough, but something that actually do more damage. We watch them. If they drop their blood count, if their oxygen drops, if anything worse, we just transfuse. And that's the other thing to be really aggressive about. You can actually point to the NIH guidelines for that. You can have, that's why if something's going on, they should call a sickle cell doctor or a hematologist that knows sickle cells, as much as don't. And if they're getting bad, they need transfusions or pheresis. And then make sure the antibiotic, double coverage. Remember, you got, the technical names, or you need cephalosporin and macrolide. But they should know that. But that covers all those strange things that won't necessarily show up on the cultures. The other is that, again, if they're really bad, try steroids, but make sure they taper them at the end. And again, the two most important things, one on here and one on the next one, if they're not doing well, call a center, call someone that knows about sickle cell. Most doctors actually, when people are sick, are more than happy to listen to somebody else. When they look like they're worse, they want to, go in, it's a little different, but that's, the things to do to make sure they mainly get transfused. Most people should go to acute chest. I've got, again, I'm not the perfect person. We've had people with bilateral and everything who are just really aggressive treating and, so far, so good in terms of what you see in the literature. We just don't luckily see it. I think it's because we are so aggressive up front. Probably overtreat some people at the expense of saving some. And the most important thing, you do SSC hemoglobin, take your hydroxyurea. Because it's the one thing that works. Look at it as a sickle cell vitamin. It's not perfect, it's not a cure, but about 78% of all symptoms go away. We've had many people that give them a new life, and the earlier you start it, the better. Because it prevents, trouble. That's what we have right now. Yesterday, or was it 2 days ago, the American Society of Hematology had this big announcement. You're talking about, You were there, congratulations. So, about just looking at this, and one of the main thrusts were, how do we get people to use the one medicine we know can, if you think about it, if you can take away, say, 50% of all the troubles in this country with sickle cell, that'd be huge. Get this going. That would be life-changing. And I have a lot of people tell me that. Unfortunately, it doesn't work for everyone, but probably 3/4 of people, they have definite improvement, and many people, they tell me, I've got a new life. And it's just a matter of keeping it on our mind. And with that, I think was I supposed to go to 10? Okay.
Thank you so very much. The next person we're going to hear from is our very own phenomenal nurse, Pat Corley. And you can read everything that's there for her. You all know her. But I'm sitting here thinking about it because, again, when I started my training several months ago, a while ago, and learning from Pat, a couple of images came to mind for me. So I'm just going to read a couple of names and ask you to think about these women and think about our very own Pat. I'm trying to cry here. Florence Nightingale. Harriet Tubman. Mother Teresa. Angela Davis. And for our newest generation, Alicia Garza, who's one of the founders of the Black Lives Matter. So for me, you embody all these women and more. And thank you for all that you've done, for all the many lives, directly and indirectly, living with sickle cell.
She's making me cry. So, this is actually not my work. This is Coretta's work. And Coretta is an incredible professor at University of North Carolina. And I'm just presenting her work because she's not able to be here. And she and I work jointly. So, there are a lot of slides in here. So when I reviewed it, I was like, yeah. Those that you will be able to reflect on and will identify with things she's sharing. So,
The clicker's right there. Yeah, that's a clicker for changing. You need the arrow. So this will come anything else. Looking at it, and then if you do want to do the pointers,
So, the objective of this talk is to describe the cultural and political aspects of living with sickle cell disease that lead to poor psychosocial and health outcomes. And then she talks about the culture and the politics, values, customs, beliefs, and attitudes. So, I don't know, some of you guys probably don't know this artist, but his name is Nazir Hertz, and he is a young man who's from Haiti who shares what his life with sickle cell disease is about through his artwork. And this is, she's using it for challenges for adults with sickle cell disease. And he certainly has had a lot of challenges from being, coming to this country and being homeless, to his artwork, where he really has not, we know him in the sickle cell community, but he should be known far more than what he's known, because the work that he does is excellent work. So the perception of sickle cell disease is that it's a genetic condition and that it's affecting, 100,000 people in the U.S. And the hallmark of the disease is pain. And although patients have a lot of other complications, anytime you talk to people with sickle cell disease, they always talk about their pain and how it affects their lives and how it's prevented them from doing the things that they want to do. And basically how it interrupts their lives. So the reality of sickle cell disease, and this is just the scientific stuff that, all of us have all gone through, where it's talking about the genetics of it, and also you get to see the sickling that occurs on the slide. So what is the culture of sickle cell disease? Sickle cell disease, for most of you that know sickle cell disease, it was first described by James Herrick, who was a doctor in Chicago, and he observed it in a dental student who was from the West Indies. And I don't know, recently they've shown things like the medical student's tombstone and where he was buried and all of that kind of stuff, just trying to make people more aware of sickle cell disease. And this was a young man who actually came from a well-to-do family. So he was in our country to study dentistry and died after a number of complications with sickle cell disease. So when they looked at the blood under the microscope, what they saw was these irregularly shaped red blood cells, the sickle and the elongated shape. And that's how they identified it was sickle cell disease. But sickle cell disease was around long before they made that announcement and that discovery, because in other countries there's a lot of descriptions of sickle cell disease that relate to chewing of bones and all kinds of stuff. So then Todd Savitt, who I had the honor of meeting, who's actually the historian for sickle cell disease, and is an incredible person, did a lot of writing and a lot of research on sickle cell disease to just see how far back sickle cell disease went. So he actually usually comes to some of the meetings, and it's an opportunity to be able to share with him what he's found, but he's very committed to sickle cell disease. So this is Wally Smith. How many of you guys know Wally Smith? I had the pleasure of traveling to Brazil with Wally Smith, and he's a really interesting person, and he is very, sometimes honest to a point of being like, wow, really, Wally? But he said the problem with sickle cell disease is that it is both rare and prevalent in historically disenfranchised populations. So it is also invisible to the American eye, and that's absolutely true. I called one of our politicians in LA when we were getting ready for sickle cell camp to find out if they could sign some paperwork so that we could get something that we needed from our hospital, the medication that we use at camp. And the woman that answered the phone said to me, sickle cell disease, didn't they cure that back in the 60s? And this is an African American woman, and I said to her, well, we certainly had a lot more visibility then. So she just started laughing. But there are so many people that I have encountered who do not know that sickle cell disease is still around and affecting people with people who live in our communities. So Coretta is basically just comparing the pain of sickle cell disease with cancer pain. And yesterday we heard a lot of comparison of sickle cell disease with cancer, and it's absolutely true that people with sickle cell disease are not identified or treated in the same way as people with cancer pain. But she was talking about how profound the sickle cell individual's life is with their pain, and how although they both suffer pain, people with sickle cell disease pain suffer from the time they're very young, and it continues to affect their life throughout their life, as opposed to someone who just develops cancer is having a lot of pain, but knows that they are going to get the relief that they need if they request it. Unfortunately, that doesn't happen in sickle cell disease. So the disparities in pain management, she talks a lot about disparities in pain management, and she has done a lot of studies on that, and how there's less adequate pain treatment for people based upon their age, their gender, and their pain intensity. And one of the things that happens with sickle cell disease, unfortunately, when we start talking to our children about pain, we don't really teach them profound descriptors of pain. So we ask them, so what's your pain like? But we don't teach them those words that they really need to paint a colorful picture of what pain really is like for them. And so that's one of the things that I want to work with, is to help people describe their pain better, so that, I don't know that it'll make a big difference, but it certainly, we can at least say we do. So provider treatment disparities are based on cultural beliefs, and unfortunately, if you look at the news, guess who you see on there who have problems with drug abuse? And so there's always that question of, if we give them medicine, are they going to become drug addicts? And my response to people that ask me that, as we see patients with sickle cell disease, is that we need to treat the pain, and then we can deal with that other stuff behind the treatment of their pain. I don't think, I've seen a couple of patients that had real difficulty with their pain medicine, but in all the years that I've been working, 90% of the patients that I've encountered did not have a problem, other than their understanding of what dependence is as opposed to addiction. Because many of the patients do not understand that that's not the same thing. And many of the parents do not understand it. And so they will tell you, I don't want you to give them a lot of pain medicine because they're going to become a drug addict. And the reality is that a lot of the nursing pioneers share that they feel like you don't become a drug addict, you're using pain medicine to manage pain rather than just taking it for pleasure. Stereotypes. There are so many stereotypes, you guys. You know, as you encounter the hospital personnel, I mean, to a point, I was actually talking to a African-American physician who was talking to his counterparts. And he said to me, well, you know, we've given her pain medicine. I don't think we should give her any more pain medicine, but she might get addicted to it. And then he's like, I'm like, well, let's just go in the room and talk to the patient. And he's like, no, my residents have already talked to her. He was a fellow. Our residents have already talked to her. And I could have been arrested. I actually had to walk to him and grab him by his arm, and I'd say, look, we're going in to talk to the patient because I have some information that you don't have, and you need to go in and talk with that patient. We became good friends later on. But I said, that's abuse. I was abusing him. But I just felt like you need to go in and really talk to the person, because what you're hearing is secondhand information. You know, so to them, that patient was getting all the medicine they needed. Oh, well, we tried to control your pain the best we could. We're not willing to give you any more medicine. And ultimately, unfortunately, we don't get consults from hematology for anything unless the patient is almost dead. You know, you have to really be pushing on them to make a consult, because they're like, well, we can handle this, we can handle this, we can handle this. And finally, you know, the patient is there and they're calling you, we need an emergency consult. So that what I have always done is try to track that patient from the time they come in the hospital so that I can intervene. And sometimes I even call the consult in, even though I get in trouble for doing it. Because you know, sometimes you just have to bite the bullet. So stereotypes related to pain in minority patients, minority people period, disenfranchised people, people who really just don't know how to maneuver systems report injustices are often there. The use of narcotics is a major concern, and it's become even more major now that everybody has decided they want to focus on opioid abuse. And unfortunately, with some populations where pain has been identified as something you just manage, with sickle cell disease, that's not the case. you know, so I don't know how we get around that, but I'm hopeful that there were 3 of us that actually popped in at the ASH meeting in Washington, D.C. So I'm hopeful that what they were saying at that meeting is really going to make a difference for people with sickle cell disease. So her quote is, if you want to be dehumanized, go to the emergency department. Is that not true?
Absolutely.
That's not true. You know, because when you arrive there, first of all, sickle cell disease, even though it is classified as an emergency, it's not treated as an emergency. It's like, well, and for me, for some of my patients that don't come regularly because they're not sick regularly, we see them every 6 months, we may see them every year, unless they have a problem and they come in. When they go into those hospital charts and they say, oh, you're not following up with hematology, then they're even more dehumanized, you know. When in reality, what we're trying to do is keep the patient functioning and moving ahead in their life rather than crippling them by having them in our clinic every week, you know. So what is a positive sometimes is viewed as a negative. And so we really have to do more education with our future doctors and with the doctors who are already on board. It's hard to change attitudes that are ingrained, but if we can start earlier, hopefully we'll be able to change those attitudes. So on care seeking for pain in young adults with sickle cell disease, and this is a paper that Coretta did with Dr. Brewer, who's another one of our colleagues, and Dr. Ataga, and reasons for delays in care response for sickle cell disease. They try to manage their pain at home. Most of the patients, because of the encounters they've had in the past, will stay at home for as long as they can to try and get that pain under control, even to a detriment, because oftentimes they know they're not going to be able to get it under control. But it's like just a few more hours without having to go down. You know, because anytime you come to our emergency room, you got to put your full armor on, okay?
Yes.
Because you are in a battle.
Yes.
So they want to avoid the emergency department because of past treatment. They want to avoid potential hospital admission because even when they're in the emergency room, once they finally got through all the craziness and they're laying in the bed and they're being treated, it's like, can you treat me a little bit faster because I need to get out of here because life goes on. So sometimes in people's head, they, instead of realizing that this is a person, I always tell folks that because you have sickle cell disease doesn't mean you don't have life. So because they want to get back to their lives and because they don't want to run the risk of losing their jobs or having major interruptions, and sometimes you have child issue kinds of issues. We have a young lady who's fighting for custody of her child because she goes into the hospital. But all kinds of things go on with people with sickle cell disease. They don't have transportation sometimes to get to where they want to go. That is horrible because there are different things that we can do to help them with that kind of stuff. There's access for getting a ride. There is, taxi cab vouchers that they haven't been given, that they should be given. But there are a lot of things that we could do to lessen those kind of things. Poor IV access is a major problem. Once they get there, and I tell patients all the time, I even told them when I was starting their IV, if I stick you twice, I'm not sticking you again. Because I feel like I'm good at sticking you. So that means I need to bring in the big guns at that point. Because no patient should be stuck. It's almost, I don't even know how to term it, but it's battery. For someone to stick you that many times and still insist that you let them continue to stick you, at some point, we as healthcare providers need to say no. We're not going to do it. We're not going to submit somebody to that kind of torture. Because they can certainly bring in machines that can identify. Did you guys, those of you that have sickle cell disease, know that you can do an ultrasound to identify where those vessels are rather than being stuck continuously. Lack of insurance is a problem for people with sickle cell disease. There's a major lack of insurance. Unfortunately, when some of our individuals get letters from Medi-Cal and different, they don't respond to those letters, and then they're thrown into healthcare systems that don't work. And then when they go to see those doctors know nothing about sickle cell disease, but they have been placed in a certain HMO because they didn't respond to their letters that they received. Sometimes it's just scary. And sometimes you should be just scared, especially if you're designated to a facility that knows nothing about sickle cell disease. And sometimes, like I said, there's a lack of child care. You know, your family has to go on. It doesn't stop because you have sickle cell disease. So nurses' attitudes and health-related stigmatization. Now, we all know that's a problem. Everybody knows that here comes the sickler, here comes the frequent flyer, you know. And some of the things that I try to really say to patients is don't allow people to use those terms with you. That term sickler puts you in a category, and it's not a positive category, believe me. I had a conversation with one of the clerks in the emergency room, and I just struck up a conversation with him about, because I was down to see a sickle cell patient in the emergency room, and I was just casually talking to him, and he said, yeah, the patients with sickle cell are frequent flyers. They come in and out of here all the time. And I was like, where'd that come from?
It was a psychosocial event.
So when I started talking to him, he didn't mean it in a negative way. He just had heard it so much. And I said to him, from now on, when you hear that term, I want you to understand that that is not a positive term. That is not a term that people with sickle cell disease would want to have used in regards to who they are. And we talked a long time. He said, from now on, Miss Pat, I'm not going to use it anymore. But it was just a casual conversation, and he felt very comfortable saying that. And I hear people with sickle cell disease feeling very comfortable using those terms, you know, and I say to them, do you want to be a person with sickle cell disease, or you want to be your disease? You want to be a sickler, you know? Because when I look at you, I don't see a sickler, you know? So oftentimes it's a matter of education. And we have to educate people, you know, because if they knew better, they do better, like Oprah said.
That's right.
So it'd be interesting to know how healthcare providers can adequately care for sickle cell patients without inappropriately administering narcotics, creating or encouraging their addiction, rating pain at 8 out of 10 when the patient is laughing, talking on the phone, socializing with friends does not warrant additional doses of narcotics. There needs to be a better gauge than what the patient reports pain to be. That's the nurse's attitude. You know, patient's attitude is, what do I need to do to help you understand I'm in this much pain? And they should not. Those things are distraction. I mean, you use the tools that you have in order to make it through that hospitalization. What do you want them to do? Lay in the bed and not move, not talk, not, you know, just abandon their lives, you know? And I say to the nurses all the time, you know, you guys should have all kinds of things for these patients to do when they come in. I mean, if they could distract from the pain some, if you could do relaxation techniques with them, if you could teach them the things that might be helpful for them, then, you know, in between you're administering the pain medicine, they'd be more comfortable. And it's just very, very difficult to get people to understand that this is they look at sickle cell disease as an acute condition. They only see most people with sickle cell disease when they come to the hospital. So they have no concept of what people with sickle cell disease are when they leave the hospital. And so Lynette and people that I've worked with, I always say, when you get better, what do I tell you to do?
Go back.
Go back and see those folks, because they need to see that you are a moving, active person who has a life with sickle cell disease.
Right.
Because otherwise they see you as that sickler in bed, such and such, in room, such and such. So you know, I know that we as healthcare providers have a lot that we need to do. But to those who much is given, much is expected, and that's my motto. But also, to those of you who have sickle cell disease, you have to really embark on a journey that changes attitudes as well. You have to help us. We can't do it by ourselves. I think those of you that were here yesterday, I said the most hated person in the hospital is a sickle cell nurse. Because when we come in, we are not nice, okay? And unfortunately, many times you get discounted, because, oh, you're just showing favoritism to them because they're your patient. No, because when my patients are wrong, they know they're wrong. I'm the first one to go in the room and close the door and say, what the hell is wrong with you? What are you doing? And Lynette will, and other folks who know me will attest to the fact that, I expect you, if I'm working my head off, I expect you to also participate in this. So that somehow we have to change nurses' attitudes, and hopefully a lot of the nurses are retiring that have those bad attitudes, and maybe we can work with some of the new nurses to change, to make sure that they don't develop those attitudes, because I know that many of the doctors develop those attitudes because the attending doctors have those attitudes. And so when they're discussing the cases with the attending doctors, they don't really have a concept of what sickle cell disease is today as opposed to what it was 50 years ago. 50 years ago they came in, the patients came in and they laid in the bed and they yelled and they screamed, and many of them had been given a magical number that they're going to die by, so they didn't have aspirations, they didn't make plans for life. But sickle cell disease is so much different today than it was 50 years ago. And so it's so important for us to work at changing those attitudes that they encounter when they come into the hospital. Charles, I'm sorry, I skipped over. You had a question. Okay, you can remember, okay?